You could also mute yourself. So and the mobile, sorry, if your mobile is on by any
Yeah,
chance.
sure.
So we have gone live. We have gone live on YouTube. We have a minute more, so we'll allow others to join. Okay. Okay, we are on time, so let's begin the session. Hi everyone, I hope you had a pleasant evening. Just started the evening and ready with your teas and coffees, freshen up your mind. So, 17th of May, before we begin the session, so let's understand the significance of today. That is 17th of May or the entire May, we can say it's designated as the World NEC Day to raise awareness on the severity of the devastating disease like NEC and also to support the tiny fighters. So, and myself, I'm Dr. Harini Manjunath, Chief Scientific Officer from Neolacta Life Sciences. So I'll be walking you through this session to understand NEC better, along with Dr. Amasundar Verma. So before we begin the session, let me give you a quick introduction of Dr. Amar. So he is an esteemed clinician who practices as a consultant neonatologist and pediatrician at the Ankara Hospital for Women and Children, Madinaguda, Hyderabad. And he's done his MBBS from the NTR University of Health Sciences, following which he pursued his DNP in pediatrics and fellowship in neonatology. He is highly skilled in treating the preterm infants and highly committed in delivering safe and high quality care to his patients. And he's known for his very soft and patientful nature in handling these infants at the critical stages. So we are glad to have him on board for the live session. I welcome you, sir, and let us understand more about the NEC in session. And also, just a quick reminder, feel free to add for any questions you may have in the chat section. So, thank you so much, sir, for joining our session, and over to you, sir.
Uh, Thank you, Dr. Harani, for introducing me. Uh, Myself, Dr. Amar, has already introduced me. I just wanted to add a few words. I'm into practice of neonatology since last 8 to 10 years of time. So I'm very interested in treating this kind of tiny babies, and we feel very happy once we see them recovering and going home with kind of smiling, especially smiling attendants actually, and with even some neonates also smile occasionally. So, so today being the World NEC Awareness Day, so I'll be very happy and just actually excited to be a part of this session, and I would like to brief you things regarding NEC, kind of what is NEC, what is a pathology, what are the risk factors, and how the symptoms are, and how we need to treat, etc. We'll be going through, and the main thing how we can prevent the NECs. So that is main thing what we need to discuss today, and we need to try to help the other people also knowing regarding the NEC prevention. So shall I start screen sharing?
Yes, sir. Over to you, please.
Are you able to see the screen?
No, sir, not yet. Yes, sir. Now we can see. And you could also hide the pop up, sir. Thank you, sir. It's very clear now.
Yeah. So just navigating this regarding NEC as understanding and how we can prevent the NEC, and what are the care strategies we need to take while treating the babies with NEC. Without wasting much time, I will go ahead and start the presentation. So the points what we were going to discuss today are overview of NEC and the risk factor for NEC, a pathophysiology, a clinical presentation, management, a prognosis, prevention, and what is the clinical evidence behind the prevention. During the NEC, it is basically necrotizing enterocolitis is characterized by death of the enteral tissue due to inflammation. So this happens mainly in the premature babies, and but it might happen really in the term babies as well. So NEC, it is a gastrointestinal disease that mostly affect the preterm infants. It is a major cause of morbidity and mortality in NICU. Even though so lots of NICU setups has been established in India, and we are treating just lots of preterms and very extreme low birth weight babies, and we are still struggling to treat and prevent this kind of devastating disease. But yes, there are very important things how we can prevent the NEC, which we are going to discuss today. So, despite the advancements in the neonatal care, NEC remains a devastating disease. So, approximately 7 to 8% of the premature infants are diagnosed with the NEC. Mortality rate ranges from 10 to 50%. So, especially in the preterm neonates with the weight of less than 1500 grams, the mortality goes up to 45%. And in the babies with less than 750 grams weight, the mortality even crosses the 50% as well. What are the key risk factors for development of the necrotizing enterocolitis? So, prematurity is the most important and risk factor for this NEC. Uh, as the gestation age decreases, the risk of the NEC definitely increases because of due to this immature circulatory and gastrointestinal and immune system of this very tiny preterm units. And again, the lower the birth weight, more the risk of NEC. So especially as I already explained, in the birth weight of less than 1500 grams, and it is almost in many babies born with the birth weight of less than 1000 grams. The risk of NEC actually increases when the tiny preterm neonates are fed with bovine milk-based infant formula or bovine milk-based feeds due to absence of the protective factors present in the human breast milk. Human breast milk has got many bioactive components which actually so which actually enhance the immunity of the intestinal epithelial cells, which will so improve the intestinal epithelial cell growth and decrease the intestinal inflammation and antibacterial and anti-inflammatory activities. Those kind of bioactive components like lactoferrin, glutamine, and human milk oligosaccharides, etc., are present in the breast milk. So this definitely breast milk, human milk based feeds have definitely decreased risk of NEC as compared to the babies fed with the bovine milk based infant formula. And coming to antibiotics, so early and inappropriate and longer usage of antibiotics definitely prevent the growth of the intestinal healthy bacteria. So, which again is an important risk factor for NEC. So, we should be always cautious to before starting antibiotics. Does the child really needs antibiotics? We need to double check while starting the antibiotic, and even if we start, once the child clinically improves and so after all the cultures are negative and following up the inflammatory markers, we should always try to stop the antibiotics or downgrade the antibiotics as early as possible as the clinical condition of the child improves. Coming to dysbiosis, so intestinal dysbiosis or imbalance of the healthy gut microbiota again will cause increase in pathogens, which leads to inflammatory response, and then it causes NEC. And one more risk factor is external transmission or even blood transfusion. External transmission through the umbilical catheter could increase the venous pressure and decrease the intestinal blood flow, causing the splanchnic vasoconstriction, which leads to the bowel mucosal hypoxia, which again might lead to NEC. So these are the key risk factors proposed to be the risk of NEC. And coming to pathophysiology, uh, so basically the first most important factor, pathological factor, is the decrease in the blood supply to the intestine. It is basically a vascular event. So decrease in the blood supply to the intestine will lead to disrupted mucosal barrier, which leads to increased storm of inflammatory mediators like TNF alpha, interleukins, and intestinal lipooligosaccharide, and even nitric oxide, etc. These all inflammatory mediators will cause a significant inflammation in the intestinal mucosa and the intestinal epithelial cells, then leading to dysbiosis, leading to increase of the pathogens, and with all these things, we could see the death of intestinal cells, and then followed by perforation and collection of the gas. So this is the pathophysiology behind the development of NEC. Coming to clinical presentation, so what are the gastrointestinal signs we see in babies, preterm neonates with NEC? The first and foremost sign what we see is the feeding intolerance. So baby is not able to digest the feeds. When we're feeding through the tube, the milk can actually come out, or even we could see the like altered aspirates, so blood stain milk coming out, and even greenish, yellowish green, or greenish aspirates so coming out through the feeding tube. And so increased abdominal girth is one most the most intestinal clinical finding, and we can also see the visible intestinal loops in the distended abdomen. And when we ausculted with the stethoscope, we could feel that the bowel sounds are actually decreased, and through the naked eye we can see blood in the stools, or even the blood stool occurred blood positive in the laboratory reports also. Sometimes constipation and even diarrhea with bloodstained stools. And as I told you, babies might actually vomit the kind of bilious vomiting, what we call it, greenish color of vomiting. So these are all the classical signs of the NEC. Coming to systemic signs, so babies might have like apnea, which is a kind of a cessation of the breathing efforts. Baby might be dull, looking lethargic, and heart rate fluctuations might be bradycardia or tachycardia, and so gradually blood pressure might actually slowly drop down, and there might be temperature instabilities, so hypothermia, you see, and decreased urine output is okay. These are all the systemic signs of NEC. Coming to diagnosis of NEC, we can do X-ray, bedside X-ray, ultrasound abdomen. What are the classical findings of NEC we see in the abdominal X-ray? So if you see a healthy bowel here, so and you can compare so this is a healthy bowel, and you can see the swollen bowel in the baby is affected with NEC. The and loops are also so dilated. So you can see the dilated bowel loops. You can compare the size. So this is the size of normal bowel loop, and this is the size of the dilated bowel loops. Okay, so dilated bowel loops, and even the thickened bowel wall with kind of frothy or soap bubble appearance pattern. Okay, so these are the X-ray findings, and so X-ray serum the diaphragm, and sometimes pneumoperitoneum. So we can see the classical football pattern, which is seen in the extreme part of NEC stage 3B, a perforated NEC, and even the later decubitus X-ray showing the intraperitoneal air rising above the liver shadow. So we always try to take a lateral decubitus X-ray whenever we doubt that we will be having a perforation. So this is called a classical football pattern. And ultrasound abdomen, it is a more sensitive method to detect the intramural air as compared to X-ray, and it can detect the intermittent gas bubbles in the liver and portal vein that are not visible in the X-rays. Color Doppler ultrasound is more sensitive in detecting the necrosis and alteration in the bowel wall perfusion. Coming to laboratory findings, so we see when we see the complete blood count, it might show the elevated WBC, that is leukocytosis and anemia, and decrease in the platelets, that is thrombocytopenia. The blood gas might show metabolic acidosis, and serum electrolytes reports might show hyponatremia. So there is a classical these three thrombocytopenia, metabolic acidosis, and hyponatremia. These three things form a classical triad of NEC. These are the classical laboratory finding triad of necrotizing enterocolitis. And cultures might grow some pathogenic bacteria in the blood or urine or stool. Coming to management of NEC, so avoid the factors that contribute to the bowel ischemia. Generally, we should manage the feed intolerance. We should withhold enteral feeding whenever we doubt that baby is having feed intolerance or early signs of NEC, and we should start antibiotic after taking the cultures, and restart the feeds when the symptoms are not progressing and the feed intolerance is actually improving. We can restart the feeds. Management staging is based on the modified Bell's criteria. Bell's criteria is stage one. It's again divided into stage 1A and 1B. So it is suspected NEC. Basically, stage 1 is suspected NEC. The systemic signs might be very subtle with the temperature instability, apnea, a bradycardia, or a dull looking baby. Abdominal signs might be so gastric residuals and abdominal so distension, or even baby might be vomiting out. Radiologically signs, we don't see any classical of radiological signs in stage 1 suspected NEC. We might see dilated bowel loops or a mild ileus, which is very non-specific, and even so this can even happen with the septic ileus also. So this is a suspected NEC. So suspected NEC, what do? We give the baby NPO without feed, and we start the baby on antibiotics after sending the cultures. We see the baby, we assess the baby frequently, and depending on the clinical status, once the baby improves after 48 to 72 hours, then if the things are fine and the cultures are negative, we can restart the feed, and we can stop the antibiotics after 3 days if the baby is doing fine. Coming to stage two, it is a definitive NEC, and it is again divided into mildly ill and moderately ill, 2A, 2B. Mildly ill, the systemic signs are same like 1A, and abdominal signs show absent bowel sounds with or without abdominal tenderness. And radiological findings are ileus and pneumatosis intestinalis, which is a classical sign of NEC. 2B, the babies will be moderately ill. They will have temperature instability, apnea, bradycardia, lethargy, same as 1A. And abdominal signs, so in addition to absent bowel sounds and the tenderness, you might be able to see a lower quadrant mass as well. X-ray will typically show pneumatosis intestinalis, which is the classical feature of NEC. The treatment again depends. If you're treating the baby with 2A, then you might need to give the baby Senpio for 7 to 10 days. And if you're treating the baby 2B, sometimes you might need to give the baby Senpio for 10 to 14 days and treat with antibiotic appropriately. Coming to stage 3, it is so advanced NEC. The babies might be severely ill with intact bowel 3A, or 3A, or the severely ill with the perforated bowel 3B. So in 3A, the systemic signs will be 2B, the signs seen in the 2B stage, plus hypotension and severe apnea, metabolic and respiratory acidosis, and disseminated intravascular coagulation. And abdominal signs same as 2B, plus signs of peritonitis with marked tenderness and significant abdominal distension can be seen. Radiological signs same like 2A, plus you can see a bit of ascites, fluid inside the abdomen. And ascites fluid might be thick, kind of when you see the ultrasound abdomen, you can see some amount of the septations, which is a classical of the peritonitis. And in 3B, the systemic signs will be same as 3A, and the abdominal signs also will be same as 3A. Radiological signs will definitely show a pneumoperitoneum in this perforated NEC. As I just shown you in the previous slides, it might show a football sign, or just free air under the diaphragms. And when you do a lateral decubitus X-ray, you could see a classical air above the liver shadow. So the lateral decubitus actually early it pick up the pneumoperitoneum earlier than the routine abdominal X-ray. Treatment. So NPO definitely for 2 weeks, fluid assist in the 3A, fluid assistation, inotropic support and ventilator support, and paracentesis in the babies, in the unstable babies and less than 1,000 grams babies, we can do a bedside paracentesis. And in stable babies with definitive neoperitoneum, we need to do a surgical repair. So it might be in section of this necrotic segment and enterostomy, or we can do primary anastomosis if the necrotic segment is not the length of the necrotic segment is not significant. Coming to prognosis, so approximately 75% of all the patients will survive. Some of the patients who survive, and even the survival rate might differ depending on the stages of the NEC. As I already told you, the mortality ranges from 10 to 75%, 10 to sorry, 10 to 50%. In the less than 59 grams, the mortality might go up to 40%. In the less than 750 grams, the mortality might go more than 50%. Of the patient who survive, 50% develop a long-term complications such as intestinal structure and short gut syndrome due to significant amount of the resected gangrenous segment. How do we prevent the NEC? So this is the most important thing what we need to discuss today. So antinatal steroids for gut maturity and human milk based feeds, which is very important. As I already told you, human milk based feeds have many significant bioactive components which have a positive impact on the intestinal immunity and avoiding the hyperosmolar feeds. So the normal osmolality of the breast milk will be somewhere around 300 milliosmoles per kilo, and even if you see the fully fortified human-based milk, the osmolality uh, shoots up not more than 400 milliosmoles osmol per kg. But when you see even the formula milk, bovine-based formula milks and all, the osmolality might be somewhere above 450, and even also some formulas might have osmolality of more than 700 to 900 also. So we should always avoid the hyperosmolar feeds and avoid rapid increase of the feeds. So every neonatal unit should have a standardized feeding regimen, standardized feeding protocol, and we should avoid the rapid increase of the feeds. So that is very important. So sticking to a standardized feeding of our regimen will definitely reduce the risk of the NEC. And we should control the infection. So we should follow the proper hand hygiene, and whenever the child the baby done invasive ventilation or central lines, so we should follow all the hand hygiene precautions to prevent NEC. So controlling infection is also a significant preventive factor for NEC. Always give preference to the breast milk. So mother's own milk or at least donor milk is very important. Breastfeeding has lowered the risk of NEC compared to formula feeding. Breast milk exams have been demonstrated to increase the intestinal epithelial cell viability and boost the intestinal stem cell activity. As I already explained, human milk oligosaccharides boosted the number of goblet cells and mucin expression, hence strengthening the intestinal barrier. A human milk based diet reduces the NEC in comparison to the bovine milk based fortifiers. Let us see the clinical evidence behind this. So, this randomized controlled trials are published in 2024. So, you can see this the forest plot is significantly favoring the human milk based diet for the prevention of the NEC as compared to bovine milk based fortifiers. And again, this is a meta-analysis from the Indian group. So even this study is also showing, this forest plot is also showing human milk based diet reduces NAC as compared to the bovine milk based fortifiers. So as I already told you, today is NAC awareness day. This month is NAC awareness month. So always I I'm happy to invite you all in promoting the hope, raising the awareness, and supporting the newborns affected by the NEC. And together we can make a better and a healthier future for all the newborns. Thank you.
Thank you so much for such a wonderful presentation and walking us through, all the details in a very understandable format. And I'm sure most of you who have attended were attending the session understood what is NEC and how critical it is in the preterm infants. So if you have any questions, please add it in the chat section. So before we start, sir, I do have few questions for you. It would be great you can stop sharing the screen. We will open for discussion.
So shall I stop screen sharing?
Yes, sir. Yes, sir. Yes, sir. Yeah, great. Now we can have it is. Thank you so much, sir. So I have a few questions for you to understand NEC more better. So now that you understand, like you mentioned, when it comes to the risk factors, most of them were related to the infant risk factors. Could you please walk us through to understand what could be the maternal risk factors that could cause NEC?
Yeah, so good question. Maternal risk factors, the common and important maternal risk factors which lead to NEC are maternal pregnancy-induced hypertension and IUGR with oligohydramnios and abnormal antenatal Dopplers as such are very important risk factors for NEC. And other things like maternal drug abuse like cocaine etc can cause the NEC in the babies. And so these are all the main things. So especially toxemia of the pregnancy, so pregnancy induced hypertension, abnormal Dopplers, IUG, intrauterine growth restrictions. So these are the important risk factors for NEC in the babies.
Thank you so much, sir. So I think by avoiding especially smoking and drug abuse, they can definitely prevent the risk of NEC.
Yes.
And also in case of infection and preeclampsia, I think they
Mm.
have to follow the guidance of the doctors to make sure that they can prevent it further. So, and also one more thing, sir, like now considering the preterm infant, you also mentioned there is a risk in term infants. So how severe it is and why in term infants?
So NEC is generally very uncommon in the term infants, but yes, it can rarely happen. As per the studies, the risk ratio is roughly like 1 in 20,000 of the live births. The term infants can get NEC. But most of the times, these term infants who get NEC will be having some underlying risk factors like congenital heart disease, polycythemia, some amount of infection, birth asphyxia, hypotension, and umbilical venous catheterization. So these kind of risk factors, especially they lead the term babies to get NEC. But the risk is very low. 1 in 20,000 live births, the term babies can get NEC.
So you mentioned about the umbilical catheterization because the central line would be needed for transfusion. And
Mm-hmm.
why is that the transfusion of blood can cause NEC?
So there are some proposed theories why the blood transfusion will cause NEC. So blood transfusion can cause T cell activation, which leads to inflammatory response in the intestinal epithelial cells, and even the transfusion might cause so immune mediated hemolysis, and even it decreases the mesenteric blood flow. So it causes the splanchnic vasoconstriction, which leads to decrease the mesenteric blood flow during the time of the transfusion, and which leads to a bowel wall hypoxia and bowel mucosal injury. So this might lead to NEC.
So it's mainly the ischemic factors, these
Exactly.
transfusion leads to ischemia and then cause
Exactly.
necrosis and NEC.
Yes, correct.
Okay. So, but then, like, let's say the doctor needs the central line. How do you think that they can manage even with the blood transfusion and prevent NEC?
So always try to avoid transfusion whenever not needed. So we follow the criteria like which baby to be transfused and what is the hemoglobin level at which we need to transfuse this thing. And even if you're transfusing, so try to make it in a kind of aliquot. So 10 ml per kilo for 1 day, and then you can see the recheck the hemoglobin level. And then if has been not improving, and then you can again try like 10 ml per kilo. So lower aliquots and duration of the transmission might so should be somewhere around at least 6 hours, not very fast. So lower aliquots and the proper time and duration of the transmission, and transfusing only to a baby who really needs the blood. So these all things are also important.
That's a good information to know. So because I know, especially the mothers, I don't want them to fall in fear that, okay, probably if they're transfusing the blood,
Yeah.
the baby would be at risk. But this is good to know, sir, that these are the things which is followed. And also like now when we see abdomen distension is one of the criteria to determine NEC and also like feeding intolerance. But there could be incidences which also causes abdominal distension. How do
Yeah.
we differentiate this from NEC and the others?
Yeah, so there are some other causes also which can lead to abdominal distension in the units. So some infection like septic ileus might cause abdominal distension, and intestinal obstruction as such. It might be actually upper high intestinal obstruction like esophageal atresia, duodenal atresia, duodenal web, and low G obstruction like ileal atresia, meconium ileus, even meconium plug, sprung disease, and even malrotation can cause abdominal distension, and some intestinal tumors, neuroblastomas, hepatoblastomas, and even significant hydronephrosis, significant renal vein thrombosis. So some other masses inside the abdomen. These all things can cause abdominal distension. But the classical thing, how we can differentiate the abdominal distension in the NEC versus the other causes are NEC abdomens are very tense and they have abdominal wall erythema, tense abdomen. Sometimes we could feel the mass. So and with the along with the systemic signs and radiological and scan ultrasound findings and the lab parameters. So with all these things, we can easily differentiate the abdominal distension is because of NEC or because of the other causes. So
So
tense
all with
and
the
yes,
yes, sir. So with the diagnosis,
exactly.
you can definitely make
Clinical
differentiate the
signs,
causes.
how the baby looking, what are the
Mm.
systemic signs. If you see just baby with just esophageal atresia with distension, baby might not look that toxic, and the abdominal wall won't look that erythematic and that tense as we see in the stages and the NEC baby. So and even the clinical findings again, radiological findings. With all these things, we can easily differentiate the findings, the babies with NEC distension versus the other causes.
So we have a question from the attendee. So that's Mitra. So he has a question. Understanding feeding human milk can reduce the risk of NEC, but can NEC happen even with breastfeeding?
Yeah, sometimes the rarely, as I already told you, prematurity and gastrointestinal immaturity is a foremost important factor for the babies to get NECs. Even though we feed them with human milk based diet, sometimes yes, they are still prone for NEC. But definitely we can, as compared to bovine milk based diet, the babies who are fed with the human milk based diet have a significantly lower rate of NEC.
Okay, so irrespective of knowing that limited risk factors, we always have to give preference to the breastfeeding.
Definitely,
And
definitely.
every mother has to make effort to breastfeed. If not, baby's
Exactly.
feeding and express the milk and feed the
Exactly.
baby.
So we always advise them to start pumping the feed once they recover from the sedation, and once they are so at least able to sit in the inclined angle. We always ask them to pump the milk, and even in the nights, even the night, some mothers won't pump. They pump the milk in the daytime, and they won't pump the milk in the night time. So even they should pump the milk at least 2 times in the night also. We should not leave such gap of almost 6 to 8 hours. At least every 3 hours, they should be pumping the milk, and even colostrum, even the few a few mls of colostrum are also very important for the small babies. So, and even we apply the breast milk inside the oral cavity of the premature babies. So even that has got a significant positive impacts on the prevention of the infections and even ventilator associated pneumonia also. The application of human milk inside the mouth has got a many significant positive factors. So we always and we should and we always should teach and train the mothers to pump the breast milk as early as first possible.
So that's a very good information because the mothers don't, with all the stress they would have undergone, they don't make
Mm,
an attempt. And
mm,
only with such awareness that importance of expressing the milk, because that is the ultimate nutrition for their infants. And that's the life-saving nutrition. They have to make an effort. And it's also good that, you stress on the point that they have to also express in the night time, giving
mm.
the duration every 3 hours. So this is good to know to keep the continuous breastfeeding rates, happening. So one more question. Now we say, like, let's say there is signs of NEC, and we have to interrupt the feeds. How long should we interrupt the feeds? Because
Mm.
every 2-3 hours is what we feed the baby.
Okay,
How
okay.
long is it recommended to interrupt the feed and restart the feed?
So when you see abdominal distension, we generally try to aspirate the feed through the tubing tube through the feeding tube, and we will see so what amount of the ml has come out, and what is the color of the aspirates? Is it altered or not? If it is only milky aspirate, less than 50% of the milk as the amount of the milk what we have given inside, and the abdomen is soft and no any significant signs, abdominal signs, and even the baby is clinically healthy, generally we don't interrupt the feed much. At least once feed we can actually skip, and then from the next feed again we can try. Even some centers, if the what they do is the aspirate is at less than 50% what they have actually given in, they try to push in the aspirate again, and then they continue the feeding. So generally we try not to interrupt the feeding much. So when the aspirate amount is more than 50% what we have given in, and we are seeing some abdominal distension, we try to skip 1 or 2 feeds, and again we try to reassess the abdomen after 2 feed time. Again we reassess abdomen, and then we always try to restart the feed as early as possible. But yes, when you're suspecting NEC with kind of some amount of systemic signs like dull looking baby, apnea, so hypothermia, so this kind of babies, again, yeah, we'll get an X-ray done, and we take some blood samples for so the inflammatory markers, all those things, cultures, and we rule out the infection. And then, depending on the clinical scenario, as I already explained in the slides, in the stage 1A NEC, it is just like suspected NEC, we can always reassess the child within a 24 to 48 hours of time, and again we can restart the feed after 24 to 48 hours after excluding the infection and making sure that the sex ray is fine and the baby's abdomen is fine, and baby is passing stool and the abdomen is looking soft. So we always
Yes, sir.
we don't try to interrupt the feed. So that's what I'm trying to tell. Some centers they are matlab, they get afraid of restarting the feeds, but I do suggest and even advise, try to feed the baby unless the baby is really not able to tolerate. So you should reassess the baby frequently and try to restart the feed as early as possible, even if you just interrupt the few feeds.
Great, sir. So also we have an interesting question again from Mitra. So it says if formula is known to increase the risk, I think this is one of the question which is trending.
Mm.
If formula is known to increase the risk of NAC, should it not be legal or regulatory mandate that formula companies put a disclaimer in the package? You must have seen the
Mm.
cases which has come up
Mm.
as well.
Mhm.
So what is your opinion on this?
Yeah, actually, they should start labeling in the so in that way, as you told, they label like human milk is important for babies. Karke, they will label, but even they should also start labeling that human milk will prevent NEC. Karke, so they can start labeling that second line also. So because human milk based diet has so definitely has a preventive factor for NEC. Correct.
I think more policy making or will actually help us because nowadays there's more awareness with the labeling of the products which has come
Yes.
and played a role.
Yeah.
So for any, even from the infant products, or even you can say from the chips to the vomit, I'm sure
Mm.
like you're known. So I
Yes,
think people
that's
are
right.
having more awareness. So I think this will be one of the things which may come up in future.
Yes, yes.
So, sir, like one more question. So we have from Chirag. So he says, according to you, what should be the ideal protocol if the baby gets NEC to resume the feeds again? I think you have covered this, but
Mm.
let's say if you have a baby initially, like preterm baby, how would you manage to prevent the NEC in that infant?
So yeah, prevention of NEC again, same thing. Human milk. So coming to antenatally, how we can prevent is whenever the gynecologist is suspecting that this mother is going to deliver the baby premature, so she should immediately try to give her the antenatal steroids. Antenatal steroids will definitely have a positive impact on the baby's gut. So the baby's gut matures well when they are exposed to the intrauterine internet antenatal corticosteroids. So that is important factor in the antenatal wise, and postnatally exclusive human milk based diet we should definitely follow to prevent NEC. And as I already told you, optimization and forming a standard feeding protocol, form standard feeding regimen for all the units, and we should stick and we should strongly adhere to the same regimen. Yes, even if you're there or not, even the shift of the doctor changes, but the feeding protocol should not change. That is very important. So strictly adhering to the standardized feeding regimen will also have a definitely significant impact in reducing the risk of NEC, and adding probiotics. So lots of studies are there regarding the probiotics like lactobacillus reuteri and bactobacillus brevi and some other Saccharomyces boulardii and some other. Probiotic adding probiotics to the human milk to the baby. This also have a preventive in the work in the prevention of the NEC.
So like
And again,
adding prebiotics. Okay.
so even the standardized feeding protocols is like the increment of the feed should be in the standardized way. So not like one doctor will come and so increase the feeding fast, and second doctor will come and increase the feeding slow. So that should not happen. It should be like a standardized. Avoid the rapid increase in the feeds also. So that is also important. And even like osmolality. So try to prefer human milk based feeds which have a low osmolality as compared to bovine milk.
Right, sir. Thank you, sir. So also like, we have almost ending with the session. So I would say that as per your experience, when you have the baby on NEC, how do you like, what would you say the mothers like, how challenging was it for you to attend to the parents? Because
Yeah.
it's definitely devastating for you and as well as the parents. So
Yes.
what do you think like are the key messages you would give them or advise them?
Advice. So same thing. So main thing we always ask them to express breast milk. So will always tell them breast milk is foremost important factor for your baby's nutrition, and it has got a significant positive aspects on the intestinal cell immunity and anti-inflammatory properties and so like antibacterial properties. All those things we will clearly explain to them. We'll ask them to try to pump the breast milk and give to us. And if the breast milk is not mother's own milk is not available, also in the second, we'll try to use the donor breast milk, pasteurized donor breast milk. So these are the things what we speak to them, and we counsel them. So if the baby has got an issue also, so don't we are treating the baby, so don't worry. We will try to restart the feed as early as possible once the baby's condition allows us to restart the feeds. So we always try to counsel them. We give them some support, moral support, and we always encourage them to for expressing the breast milk. And even
Right, sir.
we frequently involve them in the kangaroo mother care, which is very important. Again, kangaroo mother care has positive impacts on both baby and mother as well. KMC so increase the breast milk production in the mother. So we always try to involve the mother. We counsel her. We give her moral support. We try to matlab, kind of maternal involvement, so involvement is very important in the well treating these kind of tiny babies.
That's thank you so for these key messages. And I think understanding the condition of NEC, the managing, the total cost would also be very high. So listening to you, what I understand is rather than thinking about the cost, one has to step in, yeah, using the preventive strategies to prevent the occurrence of NEC, because the cost comes later. First is the prevention, and
Prevention.
one should not just worry about the cost and just make these days hell. So I think prevention is the best option to do take in care. So as now we are end of the sessions and not received much of a question, but I'm sure Dr. Amar has answered almost all the questions we have, and we have understood NEC in a better way. And I would want to take this opportunity in acknowledging the tremendous efforts all the healthcare professionals has taken up in managing this tiny infants and fighting the NEC. Thank you so much for all the efforts, and thank you so much, sir, for your time. And it was great having this session. And I'm sure we have learned a lot about NEC. And thank you so much, and have a great day, sir.
Thank you.